So again, we have the distinct pleasure today to have Dr. Michael Kramer come and talk a little bit about mapping MCH. Dr. Kramer is an MCH and social epidemiologist and associate professor of epidemiology with research focusing on social and spatial determinants of life course patterns in maternal and child health and health disparities. He is the director for a HRSA MCHB-funded MCH Center of Excellence, teaches MCH foundations, advanced methods in social epidemiology, and applied spatial epidemiology at the Rollins School of Public Health at Emory University. Thank you, Dr. Kramer, and I believe your line has been unmuted. Are you there?
Yes, I'm here. Hopefully you can hear me okay?
Yes, loud and clear. I'll
Excellent.
turn the floor over to you.
Great. Well, thank you all for spending a little of your Thursday afternoon or midday, whatever it is in your part of the country, with me. I'm excited to just talk a little bit about some issues in spatial thinking and maternal and child health. And if we have an opportunity, we may follow this up with another talk later on with some subsequent applications. So here's what I'm going to try and do in the next hour or so. First is to motivate why we might care about spatial analysis in maternal and child health, so the why question, and then to introduce two particular topics that are important if we want to represent public health or MCH data visually as maps. And that includes epidemiologic cartography and disease mapping. And in each of those, we get at some of the what and some of the how of mapping in MCH. All right, so I find it useful to start off talking about spatial analysis in public health by talking about spatial thinking rather than talking about maps. In other words, what is it we're trying to do when we represent some kind of public health phenomenon on a map? And it has to do with spatial thinking. What is it we think is occurring that we can see particularly well on a map? So there's three sort of fundamental aspects of spatial thinking, and they include describing patterns, which really is the cartography part, analyzing relationships, and making inference. So we're going to talk today, both the cartography and the disease mapping are really in that first descriptive step. But there are tools and techniques that can take spatial analysis to the next level and actually analyze relationships in space and even make inference about associations. So why spatial? So I find spatial analysis compelling in public health data because space uniquely tells a story about data, a story that often is hard to discern when data is represented in non-spatial ways. And we routinely use maps to tell stories in a lot of different settings, including surveillance. So we represent surveillance data annually or over time in maps. But we can also use mapping of population health processes to generate hypotheses about why disease risk might vary from one place to another, or to think more interventionally about where resources could best be allocated. Often, we see data, we use data in tables. And so I have the most simplest of tables in the upper right of this slide. It's a table with one row, so it's the infant mortality rate in the United States in 2013, and that's the value, and that's often how we represent data. And if we put that tabular data onto a map, this is what we see, and it's not a very interesting map, is it? All right, so often then we take tables and we break down information into subgroups so that we can say something about heterogeneity or variation in the experience of health in populations. So in this case, the subgroups are states, and they happen to be sorted inversely by their infant mortality rate in 2013, with the highest rate states at the top of the list, and the list actually goes down well below the slide. So I thought, why don't we map the same information in the table? So I have sorted the states by their infant mortality rate. Again, not a terribly informative map. What's powerful about mapping epidemiologic data is that when you put those pieces together, stories come out of the data that were not apparent when we just looked at the table, the tabular data before. when we put the puzzle pieces together, not only do we see the states that have high or the states that have low rates, but we also see spatial patterns where regions have high or regions have low rates. And that's the power of mapping. And that's the visual representation of data that we can't do as easily in other formats. So with that as a motivation for why we might want to produce maps of public health data, I'm going to talk now about two particular topics. One is epidemiologic cartography, so how to think about and represent public health data on maps, and then disease mapping, which I'll tell you about in a moment. So cartography is the production of maps, which is a visual representation of geographic data. And epidemiologic cartography, by that I simply mean that we want to visually represent epidemiologic data. But epidemiologic data is not like traffic data or weather data. There's some particular things we need to think about when we've got public health data. So I've got 4 steps that I think are really important for producing effective maps. And the first two we'll sort of talk about together, and they are being clear about the purpose, question, and objective for which you created the map, and being clear about your audience and the output. Because these two things can drive a map to be completely different in one scenario versus another. But having clarity to yourself about what your purpose, question, and objective are and who your audience is can make a big difference in producing a map that's effective at telling the story of the data. So questions and objectives. There's a lot of kinds of questions we could ask. Perhaps what you're doing is an exploratory data analysis. So you're asking whether attributes vary spatially. You just want to describe the data. Or maybe it's some sort of a health services planning analysis, understanding whether the supply and the demand of a population at need in a particular public health service are spatially aligned. Or perhaps it's a more specifically epidemiologic analysis in the sense that we're interested in an association between a risk factor and a health outcome. In terms of audience, this can also vary quite a bit. Often, many of the maps we make are actually for ourselves. They're part of steps in us understanding the data we're working with. So the map I would make to understand data for myself is dramatically different than the map I would make to disseminate at a meeting. And recognizing that's useful. What do I want to get from this map? Or perhaps you're making a map for internal colleagues. You would want to share some information about a recent surveillance report and you're interested in getting feedback from them. Or perhaps external colleagues, so still public health professionals, but at a meeting, for example. And finally, we often create maps for stakeholders that are not public health people, so for legislators or the media or the public. And those maps take particular care because we want to be sure that we accurately and transparently represent what is the data underlying the map. In addition to thinking about the objective and the audience, we also want to be really clear about the parameter of interest. What really is the thing that you want to represent on the map? And there can be lots of parameters that we have as epidemiologists. So for example, here we might be interested in actual points, households in this case, and their malaria status. So are they incident or prevalent? So they're either they have malaria in the house or they don't, and we're representing literally where they are. So that's one kind of a parameter. More typically, what I think we have in maternal and child health are parameters like this. There's some sort of an aggregate. So we've got a numerator, cases or events, and a denominator, person, time, or persons at risk. And we're producing something like an incidence rate or a cumulative incidence or a prevalence, and then we're mapping that. That means that we're inherently applying some kind of an aerial unit, a polygon, a catchment area at which we're aggregating. So that's a parameter. And then we can also actually map parameters that aren't just the rate or risk of disease, but are maybe an association or a magnitude of effect. This map on the right is a SMR, a standardized morbidity ratio, but it could have also been a risk ratio or a rate ratio representing the relationship between an exposure and an outcome. And we can map that through space, and it clearly has different properties than simply the rate by itself. Okay, so being clear about the purpose, question, objectives, and defining the audience and the output are necessary steps to be able to move forward. But then more concretely, we need actual data. We need to collect and prepare data. And so I'm going to talk about that briefly. There are 3 sort of buckets of data that we could use, and the first one and the third one, the 2 in red, are the ones that are always important if we're creating a map of health. And the one in the middle is often important, but not necessary. So first, of course, we need health outcome data. And that could be, again, at the individual level, or more typically, more conventionally, it's an aggregate of some kind. It's at the census tract or the county or the city level. We could have information about exposures or predictors or covariates. So these also might be measured at the individual level or as contextual or environmental measures. And then really importantly, and this is what differentiates the mapping process from other kinds of tabular data reporting, we need geography. We need something about space. And so we need a geographic feature that aligns with information in our health outcome data. For example, we need to know the county that the health outcome occurred in and the geographic boundaries of the county, or the X and Y location of a point and the outcome that occurred at that point. So we need to put together the attributes and the geography. I'm going to just give some examples of common types of data in each of these buckets that might be relevant in MCH. There's certainly more options than this, but these I think are relatively commonly used. From the outcome side of things, so what kind of health events can we readily access that might have geographic information associated? First, we can think of this as numerator-denominator counts, so aggregate counts, or sometimes we have information that's already created into a prevalence or rate or risk. In other words, it's already a ratio of some sort. In terms of data sources, vital records are, of course, commonly used, so births and deaths and birth-death linkages. If you're doing that, depending on what age range you're doing that over, fetal death records, maternal death records, pregnancy termination records. Surveillance systems can occasionally also be linked geographically. So, for example, PRAMs, depending on the access that you have to the linkage of your birth certificates to the PRAMs selection frame, could be linked to geographic information, or vaccination information, or reportable infections and birth defects. And then also hospital discharges, Medicaid records, WIC intake, Title X reporting, all of these potentially could be health outcome data that could be aligned with some sort of a geographic reference. Here are some common sources of these data that you could look at if you don't already have access to them at your fingertips. These are, again, not all public access health outcome data, but sources that have a lot of public access health outcome data. Okay, so the second kind of data were exposure or predictor or covariates. In other words, other attributes that we want to put on maps that aren't just the health outcomes. And again, these could be measured at the individual level or contextual or environmental. If they're contextual, they might be specific to a point, like to someone's home. Or often we use buffers, so you may be familiar with people buffering around parks to identify people's access to parks, or buffering around grocery stores to identify who has access to healthy food options, for example. And often we use fixed aerial units, in other words, census tracts or counties. And these kinds of predictor or covariate data could be used to capture a lot of kinds of phenomenon or processes, like the socioeconomic context, or the built environment, like housing quality and walkability, or the healthcare environment, proximity to the care or the quality of care. And of course, the toxicant environment is another one that's often used, air pollution, water pollution, etc. Here are just a few websites that have public access data that's relevant for some of those domains just listed. Of course, the American Community Survey census is the sort of go-to for population data. It also has a lot of social and economic data. But the other three options, Policy Map, the Robert Wood Johnson Foundation's County Health Rankings, and HRSA's Area Health Resource File, all have additional information that's often put together with a census to produce new kinds of insights. So these are all really useful sources. And finally, very importantly for mapping, we need some kind of geographic data. We need some way to connect the table that was health outcomes and the table that was, for example, poverty rate from the census, connect it to a map. And so that means we need some kind of either polygon file or points that represents where these things occur. And we can download free geographic feature data from a number of places. And common sources include, again, the US Census, where we could get county boundaries or place, city boundaries, tracts, block groups. But we also use sometimes perinatal regions or public health districts or school districts as boundaries of interest. And we can also consider, depending on the question, network features like roads or transit or water and sewer networks. And here are a few places that are, again, public access geography data that you can get both environmental features and also political boundary information. Okay, so defining the purpose question, defining the audience, collecting and preparing data. Okay, so now we need to make a map. We need to put this on the map. And we talk about symbolization as the way in which we represent data visually on that map. And mostly what I'm going to use as examples are a kind of symbolization that creates a map called a choropleth map. That's the one that we see most typically, and that's where every aerial unit, like every county, for example, is assigned a color that represents something about the underlying rate in that county or in that census tract. Thinking about color turns out to be really important. Our brains are wired to come to conclusions based on the color transitions that we see in front of us. And so people have actually done a lot of work on the cognitive science of color perception. And some of those people produced this website, colorbrewer2.org, which is a great resource that helps point you towards some color choices that seem to work pretty well for maps, that are not too misleading. There are definitely color choices that can inadvertently mislead people into coming to the wrong conclusion about a map. Some of the things that you want to be aware of with colors includes that a high proportion of the population are colorblind, and depending on how you're representing the map, for example, copying it or printing it, color choices matter. And the colorbrewer.org helps you select colors that are colorblind safe or printer friendly, for example. In addition to picking colors, if we're producing a choropleth map, we also have to think about how to assign colors to the numerical values of the rates that they're representing. And most software that produce maps have a number of choices, and it can feel confusing about what you do. Here are just 4 choices. Briefly, the upper left is called quantile breaks, where basically the entire set of counties was divided up into even buckets. In this case, 5 even buckets, 20% of the counties in each bucket. Standard deviation breaks, where the breaks are by outliers, by extreme values, who's close to the mean versus who's far from the mean. Something called Jenks natural breaks, which is a default in the ArcGIS system, and then equal intervals, where you take the minimum and the maximum and you divide up the distance in between equally. Notice that under each of these legends, I actually have a histogram of the data, and you can see that the histogram is identical in all of them. What's different is where we assign the color points. And let me just make a couple comments on these choices. There has also been some interesting cognitive research on people's ability to interpret epidemiologic maps under different scenarios of color and cut point representation. And although cartographers tend to dislike quantile breaks, what the cartographers who did this study found out was that people are typically able to better understand and describe patterns in maps when we use quantile breaks. So for epidemiologic data, quantile breaks, I think, are the starting point. I think they're the first place to go. What it does is it highlights rank order, and it's centered on median values, and it lets us see the extremes of data. Who's the top quintile, who's the bottom quintile. Now, other choices that could be useful in particular purposes. The standard deviation is really good, as I said, for outlier detection. It's not good for non-normal data, but if you're really interested in finding places that are above or below the norm to an extreme, that's a useful approach. But you can see that it doesn't do very good at distinguishing in the middle of the distribution. Similarly, the equal interval is a nice, easy to interpret system. It has equal amount of distance at each bin. But the problem is it's defined by the distance between the minimum and the maximum. So in this case, the maximum is an extreme outlier. And so there's categories where there's almost no counties that fall in that color. And then, as I said, the Jenks natural break is the default in ArcGIS. I find it rarely to be the best choice. I think it doesn't make any inherent sense for epidemiologic data. So that's my opinion. Okay. Now, another note on color, it's not just which colors you choose, it's also how they are arranged. And there's actually 3 kinds of ways we can do this on choropleth maps. The most common is sequential. So that's where the colors go from light to dark, and they represent underlying numbers that logically go from low to high. And our brains are pretty cued to see dark colors as more of something. So when we see a dark color, we know that there's more of it there. So sequential is good for representing rates or prevalence or something. Divergent colors, on the other hand, usually have some neutral color in the middle, so the sort of beigey color in the middle, and the colors get more extreme towards the outer edges. So they go to red, in this case, in one direction and green in the other. This is really useful when you have something that you're mapping that has an average value and you're trying to represent those that are above average and those that are below average. This can also be useful if you're mapping a ratio measure, like a prevalence ratio or an odds ratio or a rate ratio, because it can distinguish between those that are below the null value of 1 and those that are above the null value of 1. And finally, occasionally, I don't actually find I use this very often, but occasionally we might use categorical or qualitative ramps. In other words, they're intentionally designed to not go in order because they don't represent ordinal variables. They represent qualitatively different variables. Okay, so just some summary points on this idea of epidemiologic cartography. This may be familiar to some of you. This may be brand new. If it's brand new, I went through a lot of stuff fast. But the kind of fundamental points, I think, for making maps that usefully tell stories are that we start with clear questions, that we're really aware of and attentive to the target audience. In other words, we're producing something that will be understandable by the audience that we intend to use the map. And then that we collect and assemble valid, reliable, and meaningful data. That's no small feat, but that's awfully important. And we produce maps in a way that fairly represent the underlying data, that tell the story that we're trying to tell. Not that tries to hide or lie with the map, but that represents the patterns that we're trying to understand by making the map in the first place. No single map can do everything. Maps always filter out information. So whenever we make a map, we're making choices about what we do and what we don't tell. Okay, so that was epidemiologic cartography. Now I'm going to talk about disease mapping, which may seem very related, but it's dealing with a particular problem that's very common when it comes to mapping small area estimates of disease. And that has to do with reliability, precision, and statistical stability. So small numbers in spatial epidemiology are the same problem that small numbers are in the rest of epidemiology when we're looking at smaller populations. We have a variety of concerns. One of them, of course, is privacy and confidentiality. We don't want to inadvertently disclose information that would make an individual or their family identifiable. So I'm not going to talk much more about that, but it doesn't mean that privacy and confidentiality aren't important concerns, including on maps. What I'm going to talk about with the disease mapping, though, is the other challenge, which is the issue of random error and precision. So we're, all of us, often interested in representing the small area geographic variation of health so that we can understand the health of the populations that we're serving better. And as we get smaller and smaller areas, inevitably the number of events and the population at risk is shrinking, possibly to zero. And it's very challenging to accurately and reliably map information when the variance of each estimate is variable across the map. So this is an issue with often the numerator. Here's just an example. This is Georgia. I just took a single year. I estimated the very low birth weight rate to white women per 100 live births in each county in Georgia. You can see on the map there's geographic variation, and you can see on the legend that it ranges from 0 to 3 per 100 live births. And I also have the histogram here where we can see a semi-normal distribution except for that very high spike at 0. In other words, a lot of counties have 0. And that's not uncommon when we have rare events in a subpopulation in a single time period. Now, many of you may prepare reports where you pay attention to metrics of reliability and to suppression rules. Here's just a few that are used. National Program of Cancer Registries will suppress if the absolute count of events in a subgroup is less than 16. MCH sometimes says less than 20, and they'll suppress, or they'll at least mark as unreliable. Other metrics or approaches are to use the relative standard error. That's the standard error of an estimate divided by the estimate itself times 100, with an estimate with a relative standard error greater than 30% being unreliable and greater than 50% probably being unusable. And then some people also look at the width versus the estimate of 95% confidence intervals. The point being that there's a number of rules that we may be familiar with already about how to suppress or mark as unreliable data with small numbers. So going back to my Georgia situation, I have 16 counties that had 0 events. And looking at my top and bottom quintile, my lightest and darkest color, half of the top quintile counties have fewer than 10 events, and all of the bottom quintile counties only have 0 to 3 events. So of the counties, of 159 counties in Georgia, only 40 met the NCHS guidelines for representing the data. And this is what the map would look like if I only mapped the information that met the NCHS suppression criteria. So this is problematic for 2 reasons, because we would like to represent small area variation and very low birth weight, and we certainly recognize that small counts produce unreliable rate estimates. So what can we do? Well, there's a few solutions. Of course, one is to get more data, right? We could increase the sample size in some ways. So depending on what the sample is, that might mean going out and collecting more data, or often if it's surveillance data, that means aggregating it differently. For example, aggregating it over many years. That may mask temporal trends, but that may be acceptable in some circumstances. Or aggregating over space. Maybe census tracts are simply too small. We need to aggregate over counties. Or counties are too small. We need to aggregate up to states. But obviously, with every level of aggregation, we're losing the very information we wanted to get. So what are the alternatives? Well, the alternative is to use statistics. And when I say disease mapping, this is actually what I mean. I mean the statistical production of estimates of disease in small areas that are stabilized at least somewhat to the problems of small numbers. To be clear, statistics is not magic. It's not magic here or anywhere, and it's not magically going to fix a lot of problems of sparse data. But what it does do is improve the reliability, the precision of the data that we have. And so what we're interested in is thinking, how can we borrow statistical information from different sources in order to produce more reliable estimates of general geographic trends? And when I say borrow, what I mean is that we're going to use some kind of information from another source, like an external reference distribution. Like if I was doing work in Georgia, I might use the US rate as the external reference distribution. Or perhaps an internal reference distribution, like the rate in Georgia overall, or perhaps specifically from spatial or temporal neighbors. So I'm going to talk more about what that means. I'm going to talk about the idea of parameter shrinkage and introduce one tool for parameter shrinkage and how it's applied in 2 different ways. So let me just say first what I mean by parameter shrinkage. A parameter is like the rate or risk or prevalence of disease, and shrinkage means I'm going to take unrealistically extreme values like a 0% risk of very low birth weight or 100% risk of very low birth weight, and I'm going to shrink them to something that's more reasonable. So that's what shrinkage means, and I'll talk about how that works in a minute. Empirical Bayes is a commonly used statistical tool for doing just this, for shrinking outliers as a function of how much information is contained within them. And we're going to talk about aspatial and spatial. The aspatial word will maybe make more sense once we introduce the spatial, but the point is that one of them incorporates space and one of them doesn't. One of them ignores space. In both cases, though, they produce estimates that we can put onto maps so that we can produce a disease map that is more stable than the raw data alone. Okay, I'm going to not read all of this, but I'm just going to remind you, if you're not already familiar, that we commonly use two statistical distributions to think about disease occurrence in populations, the binomial distribution and the Poisson. And when it comes to disease mapping, the Poisson is used quite often because it's a good approximation to the binomial in the situation of rare diseases, and it doesn't expect that our population at risk is fixed. So the Poisson, remember, is a count distribution. It's modeling the expected count. And the way it works is it has a mean parameter. So I have the yi given theta I is distributed Poisson, and inside the parentheses, there's an e sub I and a theta sub I. So the parameter of the Poisson, the mean, has 2 parts. This is the main thing that I want you to take away from this slide. There's a background rate. That's the expected reference rate and that's represented in the EI. Basically what that means is how many very low birth weight babies would we have expected if this county behaved like the reference rate. So if the reference was the US average, I would apply the reference rate to the number of people in that county, and I would say here's how many I would have expected to occur. Or if the reference rate was Georgia, I would apply that. So EI is the expected count, which is capturing information about the reference rate. And then the theta I, that Greek symbol, is the local relative risk. How much does this county deviate from the expected count? How far is it above or below the expectation? And with those two bits of information, we can say that the count of events is distributed Poisson. And that means we can take advantage of some statistical tools that let us make inference about Poisson. Okay, I'm not going to say more than that. I'm not sure if how many people have bumped into Bayes' theorem before. I'm going to talk about empirical Bayes, and this is not critical to this slide is not critical to understand to use empirical Bayes, but I just want to include it in case you have seen Bayes' theorem, which is basically a mathematical statement about probabilities. And there are three parts that we talk about in this mathematical statement. And one of them is called a prior probability. So a prior probability is our initial belief about the true rate. And what I'm going to use in empirical Bayes is the reference rate as my prior. In other words, in the absence of any other information, I'm going to say my best guess for the rate of very low birth weight in Georgia County is the rate of the state overall. That's my prior belief. And then we combine the prior belief with the likelihood. That's like the conventional statistical part of the process. So we have some information. We have a numerator and denominator. So I combine the likelihood with the prior, and what's produced is, on the left-hand side there, it's called the posterior or the updated belief. Basically, it's if I took my belief about the average expected rate from the state of Georgia, and then I looked at what I actually observed in your county, and I took a weighted average of those two, I would have a new updated belief. So that's what Bayes' theorem does, and empirical Bayes is an application of Bayes' theorem. Again, we can talk about using empirical Bayes without fully understanding this slide, but I just wanted to touch on that. So when it comes to disease mapping, we're actually going to use this idea of empirical Bayes to estimate a more reasonable rate of health events for every single geographic region, and the example that I had for every single county. And what we're going to do is, again, use prior information, which is going to come from the reference rate, and we're going to combine it with the observed information, the likelihood in each county, to produce a new posterior updated information. And again, the formula is here. You can look at it if you want, but ultimately the smoothed empirical Bayes, the updated posterior belief, is simply a weighted average of the observed data and the reference data, and the weights come from the size of the population. Let me make a little bit more sense of that. As the population at risk in a given area goes towards infinity, the weight goes towards 1. And when the weight is 1, the smooth posterior rate is exactly equal to the observed rate. In other words, if there's a county with 1 million people and 100,000 events, but the rate is exceedingly high, it would not be shrunk if there was a lot of information there. So shrinkage doesn't happen the same to every county. Shrinkage happens more to counties that have small populations. And that's the power of the empirical Bayes, is that it accounts for how much information is contained in each geographic unit. The inverse, as the population at risk goes towards 0, the weight goes towards 0, and in that case, the posterior rate is equal to the prior belief. In the absence of any information, we're going to impute the reference rate into that county. All right, I'm going to show you some examples of maps that produce these in just a moment. But while we're talking about empirical Bayes, I'm going to just make the next logical step, which is how could we make empirical Bayes spatial? How could we change the reference rate to gather some more information? And here's how that works. In the aspatial, the reference rate I just gave in the example was the overall rate of very low birth weight in the state of Georgia. So it was a single number that was the same for everybody. It assumes that the prior information is the same in the northern part of the state as the southern part of the state. However, it's possible that the prior information, that our belief about places that are higher or lower are different in space. And so we can actually use that difference in space to get more precise priors. So instead of the prior being the single average rate of very low birth weight in the state of Georgia, the prior becomes the rate of the counties that are immediately around me. So they're my local prior. It assumes that the prior information varies geographically. Okay, this is going to be a little parenthetical about spatial analysis. So we're going to push pause on Empirical Bayes, and I want to talk about what does spatial actually mean when we're talking about statistics. Because somehow we have to represent who is close to whom. So spatial analysis conceives of spatial relationships as those that are connected or nearby. So spatial connection means that we share some kind of experience or exposure or opportunity. And we have to somehow take that qualitative, a little mushy, vague definition of spatial relationship, and we have to make it mathematical. We have to define how particular units are related to one another mathematically. We're going to do that by defining neighbors. So this is a grid, a fake world in which everybody is aligns on a grid, and I've got an observation at point A, and I'm interested in who are the neighbors. And there's a number of ways I could think about who are the neighbors of A. Here's the rook and queen in the chess idea, rook and queen contiguity matrix. This is a definition of neighbors that says that sharing boundaries implies interaction. But sometimes we use buffers to define neighbors. We might say that all of the census tracts or all of the counties within a fixed distance of my county are my neighbors. And sometimes we use inverse distance. In other words, we say that how much of a neighbor you are with me is inversely related to the distance you are from me. So rather than being discrete, it's continuous. The point is that we can make decisions about definitions of what is local, what is nearby, and then we can take that and make it mathematical. And we do that by defining neighbors as ones and non-neighbors as zeros. Sometimes there's also something called row standardization, which we can talk about more later if you'd like. So the idea is that we can take the pictures from the previous and for every county or every census tract say, if you're my neighbor, you're a 1, and if you're not my neighbor, you're a 0. To give an idea of what that looks like, here are 10 counties in metro Atlanta, and I have a matrix that is called a spatial weights matrix, and it is, not surprisingly, 10 rows by 10 columns. On the diagonal is each county is a neighbor to itself. So those are all zeros. That doesn't make sense to be a neighbor to yourself. But what you can see, for example, if you look at county number 1, look at whose neighbors, who it touches, who it's adjacent to, who are its neighbors. It's adjacent to county 2, 3, and 5. If you go to the first row in the matrix and read across, you'll see that there are 1s in space 2, 3, and 5. So this is a matrix that literally mathematically encodes something about spatial relations. We can take these spatial weights, these matrices, and we can translate them then into tests of statistical connectedness, and we can use this in the empirical Bayes form. So now I'm going to show you a couple examples. I'm going fast. Good. We're going to have some time to have a conversation. I was worried we weren't going to have enough time, but I'm almost done. How about that? I'm going to show you a few examples of what happens when we apply these rate smoothing, these disease mapping algorithms to the very low birth weight map of counties in the U.S. So first, I just want to point out what the raw distribution looks like. So the map is represented to highlight outliers. So this is actually a standard deviation map where the extremes of colors are the most extreme values. And using the metric of reliability, the relative standard error greater than 30%, 1,700 of the 3,100 counties have a relative standard error greater than 30%. We would say that they're unreliable. So this map of the U.S., although interesting, is not actually reliable, or it's unevenly reliable. Some counties are much more reliable than others. Another way to see how these extreme values are distributed is to look at the box and whisker plot on the right-hand side. So you can see that most of the counties are in that narrow box part, but that there are a lot of outliers, particularly outliers to very high and probably implausible rates, and also outliers that are very low, again, implausible. When I say implausible, when I say that a rate of 0 is implausible, I don't mean that it's implausible there's a county that had 0 very low birth weights. I mean that it's implausible that there is a population that has a 0% risk of very low birth weight. So when there's a 0, it's because there simply weren't enough pregnancies for whatever the low rate might have been to have produced at least one event. Similarly, for implausibly high rates, if we had only 4 births and one of them was very low birth weight, then the very low birth weight rate would be 25%, which is not very plausible. Now, from that raw data, we can do a number of things. First, this is the aspatial empirical Bayes estimate. So remember, what we did here is we took a reference rate, and in this case, the reference rate was the very low birth weight rate for the entire US. So we took a single reference rate, and we combined it with the information in each county and took a weighted average. And remember that the empirical Bayes takes a weighted average where the weights come from how much information is in that county, how many births there were. And what we get, first of all, if you look at the box and whisker plot on the right-hand side, is a far more compressed distribution. In other words, as would be expected, the empirical Bayes shrunk the parameters. It took very extreme outliers and it shrunk them. And it did that in both directions, both from 0 and from the point 1. It shrunk them down towards the mean. Possibly, it could be argued, it overshrunk them. Maybe we've lost some of the variation. Nonetheless, these are much more reliable estimates of the rates. And we can see some interesting spatial patterns that are slightly different from in the past map. Also notice that our relative standard error in this case is only greater than 30% in 28 of the counties. Now, the spatial empirical Bayes uses a different reference rate. Instead of that single overall reference rate from the whole country, it uses the reference rate from the counties that are nearby. What this does is it allows that there might be local highs and local lows, but it doesn't rely just on the information from the individual county to determine that. It uses information from nearby. So you can see, for example, looking at the box and whisker plot, that there's still more variation. Perhaps it is suppressing or tampening down the variation less than the empirical Bayes. Whether it's doing it enough is a point of contention or a point for argument. And what we see is a pattern of more nuanced detail in the geographic pattern of risk. Okay, so that was a very fast tour through both epidemiologic cartography and disease mapping. I want to spend just a moment to say a word about how you might go about doing some of these things. Of course, each of these has more under the hood than we've been able to talk about in this one session, and it takes some hands-on training. But it also takes software. Depending on where you are, you may have access to software like ArcGIS, which is the sort of industry standard in terms of GIS software, or you may not have access to it. What I've tried to do here is represent some common software packages that are used for spatial analysis. And I have them sort of divided into this grid. On the left-hand side is software that is free, and on the right-hand side is software that is decidedly not free. ArcGIS is certainly not free. On the upper two panels, I have software that is primarily for what I would call GIS and mapping. In other words, statistics is not its main purpose. Management of spatial data is its main purpose. Producing maps is its main purpose. As in contrast, on the lower two panels is spatial analysis, where statistics is in fact one of the main purposes. So notice that ArcGIS is not only a fee-based package, but it splits between GIS mapping and spatial analysis. ArcGIS was originally really for GIS and mapping, but it's developed a lot of spatial analysis tools over the years. So it's a big package with a lot of things in it. QGIS, similarly, actually does have some spatial analysis, but it's primarily GIS and mapping. And QGIS is open source. That means it's free. You can just download it from the internet. Just Google QGIS. It produces maps, manages spatial data, can do some geoprocessing. Geoda, which is in the lower left corner, is also free, and it's available from a website at University of Chicago. And it does a number of things, including having functionality to produce empirical Bayes, and spatial empirical Bayes smoothing. So if you wanted the quickest way to produce empirical Bayes and spatial empirical Bayes smoothing, Geoda is probably it. It's pretty easy to learn how to use. It works with a lot of kinds of data, and it's free. And then I have R, sort of spanning the GIS and mapping and spatial analysis. R is my personal favorite. I teach a spatial epidemiology class, and I make the students learn R just because I think R does everything that I want it to do. It does the mapping, but it also does the spatial analysis and statistics. R is free, and it does have a bit of a steep learning curve, so it takes a little support to get it to be useful for you. But there's a lot of resources online. I think I have. Okay, so some take-home points from the disease mapping and from this idea of tools we can use to produce these smoothed maps. The first is that there are many challenges to visually representing these small area data, and the privacy concerns is one, but the uneven rate reliability is really an important one, and it's one that we shouldn't ignore. Statistical disease mapping is one approach for recovering general geographic trends in data. It doesn't necessarily tell you the exact answer for every single county. What it does do is it recovers geographic variation, places, regions that are higher or lower. We talked about both global or aspatial empirical Bayes and local or spatial empirical Bayes as methods that can smooth the data. I will note that while we haven't talked about it today, there are extensions of the empirical Bayes tools to fully Bayesian disease mapping, which has much more functionality, the ability to incorporate covariates and to change the spatial relationships and so forth. There are also tools for producing non-parametric kernel density maps and other approaches for disease mapping as well. So we've only really talked about a couple, but they happen to be relatively easy to incorporate and relatively useful and reliable. And that is all I have. I would be happy to have questions or discussion or whatever makes sense.
Great. Thank you, Michael. I think what I will do now is, so everybody can prepare, again, I'm going to unmute everyone's line. So if you don't want everybody to hear what you're currently thinking or talking about, you can mute your line by doing *6 after I unmute it, or by hitting the mute button on your phone. So we'll start with that, and then I think Ashley's going to jump in and help with the Q&A. But give me 1 second here. Let's see.
The conference has been unmuted.
Thanks so much, Michael. This is Ashley, and I wanted to just really express our gratitude to you for being available. It's not an exaggeration to say that you are really our field's foremost expert in GIS spatial analysis. I think right now Mark is trying to do a quick poll just to see what you all may be using to create maps if you are using them. That might help just to see where you are in the process and what you might want help with, and that can be part of evaluation feedback as well to help shape the next follow-up webinar.
Sure. And the poll just went live, Ashley, so great timing.
Great.
While people answer that, are there any questions or comments?
Well, I can jump in and ask a few to start. Michael, how would you decide between taking a spatial or aspatial approach to the mapping process?
I think it probably depends on the ultimate goal. The spatial approach has, we are making stronger assumptions about the stability of the rates in small areas. So if we have a state where many, many regions are quite rural with small counts, the spatial approach may still not have very reliable information in the neighbors, in the prior. And so if we feel like there is information that's spread across the map, I think the spatial approach produces the most nuanced information, the most nuanced picture, but it certainly depends on the assumption that there is information spread across the map. And if there are huge swaths with hardly any events, then there will not be much information gained from that. And in that case, the aspatial, the global empirical Bayes, would produce perhaps a flatter looking map, less variation, but perhaps more reliable in terms of identifying areas that are really higher or really lower than others.
And are there other approaches to the weighting? I know you presented the Queen's contiguity, but are there other spatial weighting approaches that wouldn't be quite so variable?
Yes, absolutely. So I sped over the choices about different weights, but the decision about weights, I think, is a really important decision, and often it's the fundamental translation of our belief about what is local into this mathematical model. Queen contiguity tends to be used really often, but not for any particularly good reason. So there are approaches for including more neighbors, which would produce more information to smooth from. And one example is k nearest neighbors. So if we think about counties, most counties have 3, 4, maybe up to 6 neighbors. But we could say every county should have whichever are their 10 or their 15 nearest neighbors. So k nearest neighbors, where k is the number of neighbors that are nearby. And what that does is it helps it deal with the fact that in the east and in the west, counties are dramatically different sizes, and so the chance of having lots of neighbors depends on the shape of your county and the size of your county. So the k nearest neighbors make sure that everybody has a certain number of neighbors, and that would produce more information that would smooth. Of course, what that also means, if we said the 10 nearest neighbors for a western county, you could include nearly an entire state as your neighbor. So it does have implications on that side. And that's why I think thinking about the idea of what's the information that we can use to smooth, what is local for the particular question at hand.
Michael, we received a question online from Alice. She says, are there any free online training programs for ArcGIS? I have no experience utilizing it and recently received the software.
So there are some limited free tutorials that you can Google around for. There are some paid-for services that are not too much, and then Esri, the producers of ArcGIS, also produce a lot of tutorials that are available by subscription or by individual price. Maybe the place to start is actually to go to Esri and look for their online tutorials. What they usually do is they'll have some introductory tutorials that are free as they try to lure you into buying the next step tutorial. But you can often get important information from those introductory ones. And they include sample data sets to download and also step-by-step instructions. Another approach, I'm looking around my office to find the book. I'm not finding it right here, but if you go on Amazon and look for GIS in Public Health, there is a common workbook, a GIS lab workbook that's based on Esri ArcGIS software that teaches GIS through examples, and it comes with a DVD in the back that has data and a temporary version of a student version of ArcGIS. So that book costs maybe $40, and it leads you through a number of steps that would be very useful in getting started.
We have another question that just came in online, and the question is, Michael, are there resources you recommend to learn more how to analyze dynamic points, i.e., movement between graphic spaces, including social distance rather than just Euclidean distance or mapping spatial social network analysis?
Yeah, so that's a big question. So there are a lot of tools that can get much more complex and that can treat space in a more dynamic way, and not surprisingly, the methods also get much more complex. So there are certainly entire textbooks and courses on social network analysis and on spatial network analysis, and so there are things that you could look up again on Amazon or somewhere that would be introductions to that. There is this sort of interesting connection between what we call spatial, but is really geographic specific, and social network analysis. And that is the idea that social network analysis, you may all have seen like the network ideas of how we're connected via things like Facebook, but also how we're connected to one another in sexual networks, for example, or in other friends networks or something. The way we describe those social networks really have to do fundamentally with our distance or proximity to nodes in the network. In other words, social network analysis is very much like geographic analysis, where we're talking about distance as Euclidean. In the social sense, we're talking about social distance. So there is a natural conceptual linkage, but methodologically, there's a lot of different tools used in network analysis.
Great. We have a couple more minutes if there are any other questions.
I was surprised to see that it looks like the majority that are mapping are using ArcGIS. So I thought that might be cost prohibitive, but it looks like many of you do have access to it. I myself have more of a limited license federally, and so have colleagues who want to create maps but don't have access to it. So I'm really glad to see this QGIS. I'm definitely going to look into that. So thank you, Michael.
Mm-hmm. Yeah, ArcGIS is, I mean, it has been the industry standard for a long time, and it certainly can do a lot of things. But it sort of has grown to the point where it tries to do everything for everybody, and so it's easy to get lost in the myriad of tools that have to do with like hydrology and stuff like that. But if you have access to it, that's super. There are certainly resources to help you learn how to use it and to make maps efficiently.
And if you do locate that workbook, Michael, if you want to send it to Ashley or I, when we do some follow-up emails, we'd be happy to send a link to that to folks as well if they're interested.
Yeah, absolutely. I'll do that.
Yeah. And also, Michael, if you have any recommended tutorials for the other software packages as well, we can put links in there.
Super. Yeah, there's some great tutorials for the Geota package, which I think when it comes to disease mapping, Geota is not at all good for producing maps to share with people. It's not really a GIS program, but Geota does a great job with disease mapping, these statistical tools, and there's some great tutorials on how to use that. It's probably it's easier than ArcGIS for doing that part.
Great. Well, we just had one. Megan sent in a note just thanking you, Dr. Kramer, so I think that's a great opportunity. We're at 4:30 Eastern Time, and so on behalf of myself and our entire team, thank you, Dr. Kramer, for sharing your information today. And for all the folks on the call and on the web, thank you for participating. A couple of follow-up things just before we get off is, one, we'll be sending out an evaluation and some follow-up information. The evaluation should come shortly, and then we'll be doing some follow-up with the information we just talked about. We also do plan to schedule one more follow-up webinar, and I think the plan is before the end of the year, so watch your inbox for that invitation and for the other emails. Ashley, any other final comments from you?
Just to be sure in your evaluation, if you have specific requests or ideas for what Dr. Kramer could cover in a follow-up to this topic, that would be very helpful.
Okay. And Dr. Kramer, I'll give you a final word if you have anything else you want to say before we close the call.
Thank you all for participating, and I look forward to talking with you again sometime.
Great. Well, again, thank you, Dr. Kramer, and thank you, everyone, for joining us. And I hope you have a great rest of your day and a great holiday as we move into Thanksgiving. And we will be in touch soon. Thanks, everyone.